So now we can start with our first panel. The health situation of refugees and migrants, where do we stand? The objectives of these sessions are to understand the health and well-being of migrants and refugees, what their main health issues and obstacles are, and the progress of global frameworks such as the WHO, UNHCR, and the International Organization of Migration. But first, I have a question for you. Let's see, what are the barriers to access to healthcare for migrants? Are they financial, cultural, geographical, or all of it at the same time? You can scan the QR code and on screen to respond, and we will reveal the answer at the end of the session. So grab your phone and let's get started. Now it is my pleasure to welcome our first moderator for this session, Luciano Sasso. Welcome. He is a member of the executive committee at the M8 Alliance of Academic Health Centers, Universities and National Academies, and a professor at the Sapienza University of Rome. You have the floor. Thank you very much.
Thank you very much for the introduction. Good morning to everyone. A very warm welcome. It's a great pleasure to be with you today. I want to thank very much Antoine Flahot, Eric Comte for the organization of this day dedicated to migration and health. I want to echo what Carl said, that is really important to dedicate enough attention to this topic that unfortunately is quite neglected at the moment in Europe. Also, it was mentioned quickly that we have European elections, and in this kind of topics, I think should be brought to the attention of the European citizens because it's a very important, topic for Europe. As Italian, I feel that really migration is so important. We Italians emigrated, to many places in the world in bad conditions, but not as bad as the condition that, migrants today face. They die to reach Europe. This is not acceptable in my view. If we really want to walk, the talk, we want to really live according to the values that we preach. So this day is co-hosted by the World Health Summit and the Lancet Migration. Just a couple of words about the World Health Summit. I'm a member of the Executive Committee of the M8 Alliance. The M8 Alliance is an association of prestigious universities, academic health centers and national academies based in Berlin, in Germany, and is the backbone of the World Health Summit, which is organized every year in October in Berlin and also in other continents, in the so-called regional events. So just a few weeks ago, there was an important event in Melbourne, in Australia, in which the topics of global health were addressed from the point of view of the main issues in the South Pacific. Next year, in April, we will gather in New Delhi, in India. So it's an important organization, and I encourage you to attend the meeting in Berlin in October, and also to visit the website of the M8 Alliance, where you can see many events organized around the topic of migration and health in the last 10 years, with several sessions also online after COVID. There are videos and many interesting information. So before we start the session, we have another important, very, very short but very important initiative. WHO launched 5 years ago an important festival, film festival on health for all. And Sunday, the winners were announced, and there is an important special prize to the topic of migration and health, and the winner was a very important, very nice movie called Dalal's Story. And today in the room we have the producer of this movie, Alexandra Kordiux. If you would like to say just a few words very briefly about your movie, and then we will screen it quickly. Thank you, Alexandra.
Thank you, and good morning, everyone. It is really such an honour for us to receive the award for this film, Dalal's Story. We focused on animated storytelling for our client STARTS in Australia. That's the service for the rehabilitation of torture and trauma survivors. So the aim of this film was to bridge a gap for health workers to provide equitable and dignified, compassionate care to refugees and really understand the refugee experience in order to improve their healthcare models. So thank you so much. Thank you to WHO for having me here today. And the festival has been a fantastic opportunity for us to get this project into a global platform, which makes us so proud. Thank you so much.
Now we're going to watch the movie.
In the Sinjar province of northern Iraq, Dalal, a Yazidi woman, was living with her husband Kudayda and their 3 children. The Yazidi people, also known as Yazidi, are said to be one of the world's oldest religious groups and have a history of facing persecution. When Islamic State fighters came to raid their village, they massacred thousands of people and forced many to flee for their lives. These crimes were not the first time that groups have tried to wipe out the Yazidi in acts of genocide. Dalal and Kudayda tried desperately to get their children to safety, but Dalal and her daughters were captured and imprisoned by IS. They were among 7,000 other Yazidi women and girls taken as sex slaves in the Sinjar area. After 6 months of abuse and slavery, Dalal and one of her daughters managed to escape and were reunited with the others in Turkey. Dalal's youngest daughter was never returned to her family, and Dalal's world felt shattered as she carried the burden of not knowing her fate. In Turkey, Dalal's family tried to find work and access education in the city, but this proved near impossible. Dalal knew there was little chance of a meaningful future for them if they remained in this situation. After what felt like a lifetime of waiting and hoping, Dalal and her family were finally granted refugee status and were accepted for resettlement to Australia. They traveled across the world in the hope of making a new life for themselves in safety. Dalal and her family had experienced many changes after being resettled to a small Australian town which felt a world away from their past.
When working with people from a refugee background, we need to consider their traumatic experiences before arriving to Australia. Could include physical torture, psychological torture, as well as deprivation of food, health, education, shelter, and then the challenges of settling into a new country, as well as the everyday life stresses that they may experience, which we all experience, and how all those 3 factors can impact in their ability to settle in a new country and also recover from any existing mental health challenges that they are experiencing. All those things really do impact on the way that a person does interact with services and receive services.
Things became harder for Dalal. Traumatic memories came back in nightmares, and she increasingly felt fearful of others, not knowing who she could trust. She spent many days crying, thinking of her daughter who remained missing, unable to even get out of bed.
If refugees and asylum seekers do not receive or access to services that might be able to empower them or to build their strength, they might develop severe mental health problems. They might also be hospitalized for a long period of time.
As Dalal's mental health worsened, her eldest daughter Nadia assumed much of the household responsibility, often interpreting for her parents at appointments instead of attending school. After many difficult months, Dalal began to access practical mental health supports and eventually trauma counseling, both using interpreters.
Refugees and asylum seekers have strength and resilience. Everything that they had been vanished, and they restarted their life. And to be able to build on their strength, they can become independent and they can be empowered person that can contribute into the Australian system or way of life.
Alongside her family, Dalal began to find ways to manage the symptoms of her depression, building on the resilience and strength that had brought her this far to help her through the next stage of her life.
Very beautiful and touching. Thank you, Alexandra, and congratulations, and also thank you to WHO for this very important initiative. So without further ado, I would like to introduce the panelists. We have a distinguished list of panelists today. Santino Severoni, Director of the Health and Migration Department of the WHO. Please welcome him. Alan Maina, Chief of a Public Health Section of the United Nations High Commissioner for Refugees. Poonam Dhawan, Director of the Migration Health Division of the International Organization for Migration. Bernadette Nirmal Kumar, Co-Chair of the Lancet Migration European Regional Hub. And Kay Marcus, researcher at the University of Geneva and the Tsinghua University in China. And Katia Gamazina from PATH. She's a leader of the Ukraine country program and also hub director of the Eastern Europe Asia hub. So please, Santino, you have the floor. We have the first round of intervention, and then at the end we will open the floor for discussion. So please write down your questions and be ready to ask them at the end of the panel.
Thank you, Luciano. Good morning to everybody, dear colleagues. Thank you, Carl and Eric, for organizing this important day and for having me here with you. And thank you also to Lancet for the work done with the Commission that in many aspects has been inspiring our work at WHO that today we are implementing. It's a time of big changes also for us. We are actually bringing health and migration as a new page of public health area of work of WHO. So thank you for the collaboration and for giving importance to this topic. I don't have a proper presentation, but I thought to, especially after this touching movie, to bring you some information to have an idea of what is the landscape, what is the context we are today living. And usually there is always a very, how to say, negative narrative around this area of work. So I wanted to focus on what is changing currently. And key initiatives also to open up to collaboration. Carl was referring to networking researchers. Carl, I'd like to inform you, a news, we are establishing a technical advisory group at WHO, try to build up a network, a global network of researchers working close with us. And then some examples of progress at country level. So the first point is related to the policy landscape. There was reference even before in the opening to the importance of policies. And I like to underline that this is a new technical area. The policies on health and migration are pretty recent for the health sector. Actually, I would like to say the health sector used to be not really much involved, only in case of emergency or the population movement would become a crisis, so health sector was feeling to be involved only to address the possible health implications. That's wrong. Also during COVID, we see how important it is to factor in health really at the early stage of policy formulation. And the current landscape confirming this new engagement of the health sector. Imagine that the first resolution on this topic was in 2008 during the Portuguese presidency, aiming at encouraging member states to have a more sensitive health systems towards migrants. But not much happened, not because member states they were not pay attention to this topic, but because instruments were lacking, evidence, normative work, data. So there was a huge gap on how to move on these recommendations. We had to wait until 2016 on the time when member states engaged into the negotiation, which led then in 2018 to the two compacts, the one on refugees and the one on migration, to really making them to understand was important to have something more comprehensive, more established in this area. So a new resolution in 2018 was adopted in WHO, the 7015, which actually gives us the mandate of what we are doing now. This means that for us, the topic of health and migration or health of mobile population, so including refugees, is not only an emergency concern, but it's really a long-term element for relevance for the health sector. We had to reach the 2019 to discover that the environment is pretty complex. In 2019, when the resolution and the first WHO ever global action plan on the health of refugees and migrants was adopted in a very skeptical, a very difficult political context, because the topic was scaring member states to engage in promising new conceivement, new commitment to beyond the capacity of the health system. So you can imagine how the negotiation, the health diplomacy, the technical work has been important, because there is no discussion if you don't have ready evidence, data, facts in order to support your advocacy and your engagement. As mentioned before, the Global Action Plan, in a totally different context after the first 5 years of work, was extended until 2030, with actually a very strong commitment, reaffirmed commitment of member states. What is important in this process of a little bit more a decade, that we had a paradigm shift from emergency concern to long-term concern, how the health system could include those populations. It's important to say that the two compacts have been aligning, or we've been aligning with the two compacts through the Global Action Plan. There are precise reference to the work of the WHO and the health sector. This is important as a guide for the member states. But the GCM and GCR had a plan to have a very effective monitoring of the progress of the implementation of the two compacts. But nothing was there in terms of analyzing how the health sector was moving. So last year we had in Morocco, together with IOM and UNHCR, the third consultation, which allowed us to take stock of the progress. We have 50 countries, member states, attending the consultation, and it was incredible to see how the health sector is actually bubbling, changing, committing to this topic. And many initiatives have been also following this consultation. So we soon understood that it's important to make this appointment regular and to link it in a stronger way with a review that the two compacts are undertaking on regular basis. I'm in a temple of research. I'm in a university. Our world report we launched in 2022 highlighted few concerns. And one of the most important is that we were unarmed, we were ready, we were unprepared in terms of understanding the mechanic of what is happening in the health sector because of population movement. The situation is very complex because it's influenced by a number of factors, many of them out of the health sector, so it was important to engage into research. And research for us is essential because we soon realize that even all the evidence, normative guidance work of WHO is supposed to be recasted, retuned, factoring the issue of the health of migrants and health refugees, because nothing was there. There was no reference, so really difficult to move on to generate progress without repositioning this topic within the public health sector. And prioritizing the research is paramount because we need more research, particularly at country level. What we see today is that few elements of matter of concern, that close to 98% of the financial resources for research are channeled to academic institutions located in high-income countries. And what is the result? That we are looking at the reality like in an in vitro situation. So instead of engaging local community or countries in a low-income setting where usually displacement, migration tend to originate, they are not involved into the process of generating the evidence. So it's very important to invest into increasing quality and accessibility and engagement in the research area. Last year, we had an important, not to forget, as we speak, the research agenda we launched in 2022, it's actually rolling out in 3 regions: EMRO, Middle East, Afro, and West Pacific. So please come forward if you like to engage in a more in-depth collaboration. What is happening at country level? As I said, the situation is changing, so we are closely looking to the reality. We are monitoring what's going on. And after the initial period of implementation of the Global Action Plan, where we saw some hesitancy, but mostly because of anecdotal type of understanding of the topic, as soon as we start to move, increasing the quality of evidence, data, and policy formulation, we have started to see a process of engagement of member states, regardless in the north or in the south of the global south of the world. And today, as we speak, about 63 countries in the world, they are having strong commitment, they're implementing inclusion of migrants and refugees in their own national health policies and actions, or provision of services, so in a different form. Just to give you a few examples, one of the first ones starting because pushed by the necessity of the Syrian crisis was Turkey, but it's interesting to see how Turkey reformed the national system with establishing close to 1,000 new primary health care facilities or specialized healthcare facilities, inclusion of refugees into the national system workforce in order to scale up capacity to address the health needs of this population. I was recently in Colombia, where it was fascinating to see how the health financing reform has been bravely launched by the Ministry of Health in a country which might be also having some other issues, as you know very well, but there 3.5 million of migrants have been granted universal health access to health sector, and 1.4 million have been provided of the plastic card for accessing as a national to the health insurance, health services. Uganda is a country committed to work on assisting refugees, and it was interesting to discuss with the Ministry of Health, which is really try to find a way, again, in terms of health financing reform to include 1.4 million of refugees into the national health system and access to services. Chile just launched recently a national action plan in order to strengthen access of migrants and refugees to health services. And a number of other countries around the way. We have also champions, like the case of Thailand, where the universal health coverage, it's a mantra, it's a way of thinking and proceeding. To go and assist countries, to stand by the countries, pose us, as you can imagine, the immediate challenge that we were not having many instruments to do that. So in this recasting the available instruments and evidence within WHO, we understood that in order to be able to put the hand into the health system, in order to somehow influence changes or reform the health system, we're supposed to have a tool able to read the reality. So we had to develop ad hoc new tools to do that. We developed a tool to revise, to assess the health system at country level, to see how the health system is really functioning mechanically in responding to the need of this population. So this brand new tool has been run already in a number of countries like Thailand, Bulgaria, Czech Republic, Jordan, Uganda, Estonia, and we are preparing for South Africa and Chile. And it's interesting to see that once we went to Ministry of Health with the evidence showing what is functioning and what not, this has been triggering, in all the cases, major engagement to upgrade, improve, or fill the gaps. Capacity building. We cannot have an health system without healthcare workforce. Often we forget about them. We refer to them only in relation to migration of nurses and healthcare workers across the borders, but in reality we need people on the ground able to understand this topic. And we realized again that there was a caveat. There were no competency. It was not clear what kind of competency healthcare workers are supposed to have in order to be able to address the public health aspect of population movement. So we developed the competencies, and we are implementing them now just at the beginning, because the number of countries coming knocking and say, I want to have that support, that assistance is growing. At the moment we are in Nigeria, Niger, Mali, Senegal, Estonia. And interesting, we were reached out by Harvard asking to use the competency as a framework for the tailoring of pre-services in the Harvard-run hospitals. Targeting policymaker is essential, so we casted the global school. It's an appointment, annual appointment, which is moving from a region to another region. This year we are in Colombia. Last year we were in Africa, in Senegal. But in the last, since 2020, the school has been training 12,000 policymakers and researchers. And we've been attending the school 178 countries. So as you see, there is demand. If you put forward concrete tools, concrete opportunity for developing, there is a response. Last, my point is related to climate change. Climate change, it's an issue which very often referring to migration. Indeed, climate changes might be important triggers for population movement. And was interesting to note, last year I was at the COP28, that we took 28 years to have a health day in the COP. Although the health implication of climate changes, they are very clear. Although the link between climate changes and migration is very clear, or displacement. So I was just wondering and try to understand why this gap. Again, we are fantastic in launching initiatives, but very often we are in difficulty to connect dots, to have a cross-cutting linking of complex reality. So last year we had a first health day. This is going to be a regular appointment in all COPs, so let's use it for advocacy and presenting our work. But also we realized that there is very little clarity for the health sector in understanding or really observing the mechanic, the intersection between health, migration, and climate changes. And this is very important if you want to advise actions. And again, even more important was to note that some communities already utilizing migration as an adaptive strategy. Already it is taking place in many areas. It was interesting to see that in the, I call the clan of climate change as expert, the topic of migration doesn't have the perception we are having usually. It's not considered such negative topic, but it's considered a response, an adaptation, an issue of resilience to climate change, as a way to combat climate change. So somehow there is a positive perception around immigration. We should build on that. We should build on that and use that as an opportunity to really change the narrative around migration. But again, what came clear is that the health systems need to be able to follow those local solutions, those local adaptive strategies, and we are not there because more inter-country cooperation is needed, more sharing of services across border is needed, more sharing of healthcare workers across border is needed, especially in those areas where the climate changes are triggering rotational type of migration or adaptation to the local context. So in conclusion, the situation overall is changing, and I'm optimistic by nature, but I like to see a changing world in the right direction, and we should be persistent. I believe that we know very well what are the issues to do once we clarify how the mechanic, how the science can clarify the unknown things or the caveat or the gaps, but commitment now is there. So the topic is on a direction of really changing the health system understanding of how important it is to not only the humanitarian, the compassionate part, but it's also good investment. It's also a right policy and political choice for the health sector to include all population in order to increase effectiveness and capacity. Thank you so much.
Thank you. Thank you, Santino. Very interesting. Alan, please, you have the floor.
No, thank you very much. And again, congratulations for this event. And it's very nice to see such a big crowd of people. I mean, the thing I was talking about, the health of refugees and migrants, after speaking just right after Santino, is that it tends to cover a lot of things that we would naturally want to say together. But then I'll also highlight some few additional points. I think it's eloquently explained the challenging times that you're living in. And I'd like to highlight some 6 points about the things that we're discussing today. Again, reminding us the numbers, we couldn't say it hard enough or more than enough in the sense that we're living in very worrying times with right now over 100 people displaced. It was 114 million by the end of 2023. And among these, we have internally displaced persons and also refugees, over 30 million refugees. It's really worrying that the numbers are still growing more and more, and the conflicts continue to rise. Santino just mentioned about the effect of climate change, the devastating effect, and we're seeing that, especially in the Horn of Africa, with famine and drought. And we have a mix of situation where we have people migrating or when people are forcibly displaced because of a myriad of factors that could be prevented. And what we're not doing right is just preventing or dealing with the root causes of displacement, the root causes of migration. We're not discussing it enough. We've seen that it's quite disappointing in the international arena that there's no consensus in the international community. Among the people that we depend on to make the right decisions and the right calls, you see a politically driven narrative that is not heading in the right direction. And people are suffering. We've just seen the excellent video that has just been shown right now about Dalal. And this is exactly what happens. Somebody is suffering, moving across the border, first suffering from sexual and gender-based violence, mental health challenges, while we are debating on political realms. We have 1 in 73 people being displaced. And it's very worrying that we will be able to reach a point where it feels like it's normal, that just numbers continue to rise and conflict continues. Sudan's situation is very worrying just to see that since April last year, we thought this would be an easy fix. We're still not far from finding a solution. It's not in the media. we've seen also in DRC, sexual and gender-based violence in levels that we've not seen in a long time, very worrying levels. We've had media release from WHO, UNHCR, and our partners, but it's not getting the attention that it needs. We need to really rise up to be able to advocate for change that is meaningful, and that we put the face of the people that are affected in our speeches and everywhere we go, because it's not just it's more challenging to address the fact that people are displaced, and that we need to ensure that they have access to services whenever and wherever they need them without suffering financial hardship. But they really want to go home. They really want to go back home, or they want to be resettled to Australia or other places. But a lot of them are not getting that opportunity to rebuild back their countries. And so that's one point on the worrying times that we're going through. Again, on the UHC, as we've said, all of us, it's great that we had the political declaration last year, Resonating Voice, a strong piece of document that countries have come together in solidarity to say we will not leave anyone behind, regardless of race, gender, or other factors. They will be provided healthcare services on par with nationals. And that means refugees and migrants need to be able to access services on par with nationals in the countries. But we've seen several challenges, bottlenecks, administrative bottlenecks, legal dilemmas that they have to go through to be able to access services. So there's still more to be done to be able to ensure that. But we've seen a lot of good progress and promising commitments by many countries, which brings me to the third point, that there is solidarity and responsibility sharing happening. Santino has talked about the global events that took place since 2018, when you had the two compacts, the Global Compact on Refugees, the Global Compact on Safe and Orderly Migration. And this has generated a positive momentum. We've seen with the Global Action Plan, promoting the health of refugees and migrants, happy that it's extended to 2030. We've seen Morocco taking lead in this meeting that we had 49 states signing a Rabat declaration that speaks strongly about country-led action, and we're seeing these countries making a lot of commitments to change policy to ensure inclusive health implementation plans. And then we had a big event, the largest gathering on refugee matters, the Global Refugee Forum, last year in December, where we had, at least for health, we had over 230 pledges made compared to 96 in 2019, a significant jump. And it was encouraging because in the midst of a very dire financial outlook and sad conflict situations happening around the world, a time when you really lose hope in humanity in a sense, all these people came together and be able to say, no, we're going to make a difference. We're going to put politics aside and make a pledge to include refugees in national systems. We had two major pledges, one on national health, inclusion in national health systems, and one on strengthening or mental health and psychosocial support services. And it was amazing to see this kind of commitments. One example is Chad itself. Chad made a pledge that despite the economic hardships we're going through, the climate change effects, and hosting of 1 million refugees, we're going to pledge that at least 50% of the facilities in those remote areas run by humanitarian partners, we're going to take over those facilities. They're going to be handed over to Ministry of Health and run by Ministry of Health. That is inclusive leadership, inclusive practice. That's a pledge over the next 4 years. But then we have such countries making such pledges, but they need support. They need the international community to come and help them. And this is why we're looking at new models, working with development actors, with the private sector, and academia, and even civil society groups to be able to support such countries that are making these pledges to be able to provide inclusive health services, noting that it's more cost efficient to have health services run and integrated in the national system rather than a parallel approach. But also with the UHC principle is to ensure that they get quality services. And it's not that the refugees and migrants in Chad, it's also the host communities, that they get quality services. That we support these countries to reach the level of quality services that needed to be provided. That brings me to the next point on the refugee and migrant resilience. I mean, these are people, and you've seen also the word resilience being referenced in the film, and it's amazing that we realize, even through the mental health and psychosocial challenges that refugees and migrants go through, they are resilient people, and they can make a difference in the society if they're given a chance. And so we are advocating more that they are empowered, they're able to have the right to work, they're able to be educated and be certified. In the Global Refugee Forum, we had a refugee nurse from Togo who's based in Ghana, and she was able, as a refugee, to study and become a nurse. And now she's giving back to society, not only to the refugees, but the host community, the nationals in Ghana. And she's a refugee health advocate, showing that they can be able to contribute to the economy of the country and the needs of the country if we give them a chance. Linked to this as well is the fact that we don't have adequate evidence to show that the needs in the refugee settings. With over 50% of refugees in urban situations, it's easier to get this data in the camp settings, but then in out-of-camp settings, we're advocating, and it's also in the Global Action Plan, that we can have disaggregated data and be able to show the public health situation of refugees and even migrants in these countries. I was in a discussion in Jordan with the development partner group, and they noted the importance of this data disaggregation. And I was happy to see that the demographic health survey included nationality and refugees, and that informed the development partners group commitment to extend their what is called a multi-donor account that was ending this year. It helped inform, provide evidence that they would be able to use to extend the funding over the next several years. And that ensures that refugees in that country can be able to access the non-foreigners rate, be able to access health services on par with nationals, a country that has 80% of refugees living out of camp. This is why we believe in this research agenda, and we're happy to be part of partnering with WHO with this global research agenda, and looking forward to the network. In the Refugee Forum also, we had a group of 10 academic partners making a pledge on increasing evidence around health inclusion, but also providing sponsorship for refugees to be able to learn and become medical staff or nurses and doctors. Just to show how this is, in the last point in terms of data, we did a study in about 50 countries where we have UNHCR-supported health interventions, and we're seeing 80% of them have included the refugees explicitly in their national policies. Again, this gives us hope. Again, including refugees in the policy is one thing, practice is different. And we're seeing, at least in about 60% of these countries, they have a national health insurance program, but only about just under 50% of them have refugees included. So we still have a situation where refugees cannot access some services at par with nationals in many countries because of lack of the limiting of the financial hardships that they go through. Just last point, just to say, again, re-emphasizing the point on UHC, that we should not leave anyone behind, and really mean it, including refugees and migrants, and ensure that they're included in national health policies, in the development of those policies and actual implementation of those policies. Thank you.
Thank you very much. Thank you, Alan. We move to the next panelist. Poonam, please, you have the floor.
Thank you. And thank you very much again to the organizers of this event for inviting the International Organization for Migration. A big congratulations to the Lancet Regional Group in Europe, and the team from IOM looks forward to your event later today, and also to make new connections and revisit old ones. Very happy to see Carl here as well. So at IOM, as the UN Agency for Migration, we are of course also very enthused to see an entire thematic day here at the forum dedicated to the topic of migration and health. And we trust that this will be the first of many in the years to come. Very happy to be here, of course, with our partners, WHO, UNHCR, but also stellar partners coming in from the civil society, the academia, and it is indeed great to start off this day dedicated to migration with this discussion. A lot has been said already, and I do want all our panelists to also have sufficient time, so I will keep a stopwatch on for myself. But just wanted to start off picking on something that was already mentioned by both Santino and Maina on this issue of working better at the interface between policy and practice. We've already heard that we now have the privilege of having a global action plan on the topic. We have the Global Compact for migration as well as on refugees. But we need to recognize the urgency to ensure that these frameworks can indeed be translated into action. Action both within governments, but then also action within societies with the larger group of stakeholders that this forum brings together, and action that also recognizes the positive contributions that migrants themselves bring to development and to societies, how they themselves can be part of creating durable solutions. We learned this through the pandemic response as well, where on paper, whereas there may have been a commitment, and I would also say a political will to ensure equitable access to testing, to treatment, to vaccination for all parts of society, including migrants. When IOM teams in the field reached out to migrant communities or worked in cross-border areas, the reality in practice was unfortunately very different. And we have to collectively, as a public health community, look towards the future when we talk of resilience, when we talk of preparedness and response, by identifying answers to that critical question on how do we ensure implementation of these good measures. Solutions often also lay outside the health sector. And as the public health community, we also have to begin with that recognition that we will need to work with other sectors. Coming as I am from IOM, we work very closely with labor sector, we work with immigration authorities, border officials, all of whom play a key role in working together with the health ministries and health stakeholders to identify solutions. So really based on our own experiences, this whole of government and whole of society approach cannot be emphasized enough in order to achieve the goals that we have laid out for ourselves, whether within the Global Action Plan, the GCM, or the GCR. Secondly, and this is where I'd like to share a bit more also about our own strategic approach at IOM and what we aim to achieve in the coming, say, 4 to 5 years, working closely with our UN and other partners. At IOM, we are committed to a three-pronged approach in terms of our strategy for the coming 5 years. Number one, we want to ensure that all our work in migration health ensures that we are saving lives and also protecting those populations that are on the move. You've heard already from Santino and Maina, there is a very diverse group that we are talking about when we speak of migrants, people on the move, displaced communities. And this is really about ensuring that we bring that health protection to all these often unreached populations. Secondly, it's about promoting durable solutions to displacement. How can we strengthen health systems? How can we be better prepared, whether it is to address the root causes of displacement due to conflict, whether we are talking about natural disasters, and how can the health sector be a part of the solution? Whether by ensuring the right competencies for the health workforce that we heard about, or whether by ensuring that there can be more flexible approaches to bringing health-related services to those who need it the most. And last but not the least, the third strategic approach that we are going to focus on is to facilitate and better strengthen regular pathways for migration, which can then in turn not only enable both societies in need as well as those looking to migrate for various reasons, a protected and a more dignified and well-managed pathway, but can also then indirectly support us in both protecting as well as ensuring durable solutions. In all of this, we look to working very closely in partnership, and our DG has also been emphasizing the need to bring new partners to the table. So very encouraged to be here in the midst of this rich group of academia, but also looking to hear from you, how can we better promote public-private partnerships? The private sector, of course, is a key player in this world of migration and also stands to benefit through innovative and flexible solutions towards ensuring regular pathways. How do we better engage with communities themselves, whether it is to correct the often wild narrative, let's say, as Carl mentioned, that may not be evidence-based, and how can you then advise us as to how better to communicate this through the various mechanisms the UN has, one of which now is also the UN Network on Migration, for which we are the Secretariat. And we will definitely bring forth the launch of the European piece here today to the network secretariat as well. But how do we break the sometimes bureaucratic processes that prohibit us from working better together in an agile manner? In terms of the actual work on the ground, of course, we can share a lot about how IOM teams around the world, operating in nearly 170 countries now with 20,000 staff, largely national staff, are working closely with governments, but also when it comes to health with country-level teams of WHO, UNHCR, and other partners. Santino already referred to some good successes we are seeing at national level. I'd like to name a few, for instance, the Philippines, where I was just a few weeks ago, where we have been encouraged to see how the government has established their own migration health network, which sits within the Ministry of Health, but is essentially comprised of representation from all the various sectors, whether it's the overseas Filipino workers, whether it's the unit working with private employers overseas, whether it's their interior or border authorities. And we need to do more to showcase these examples and also use them to promote further country-level implementation. Similarly, we've seen encouraging work being done in North Africa along migration pathways. For instance, based out of Morocco, we are able to support the governments in several North Africa countries to provide direct services as well as access to health for those who are taking those migratory routes, often not in the most protected manner. Maina mentioned Sudan, and indeed a very complex and challenging operating environment where, again, from experience in working with local authorities, we've learned the need to be agile. The only way we've been able to bring access to communities in need has been through operating mobile health teams, for example. And these are the types of solutions that we need to recommend where they are needed the most. And we need to make sure that the key global health donors, I don't know if there are any here in the room, how these key global health donors can also ensure that the funding follows the people on the move and is not given in the traditional static manner where oftentimes health-related bilateral funding tends to respect national borders. A last remark I'd like to make before handing over to the next panelist is also similar to what Santino said around the issue of climate change and mobility. At IOM, this is another key priority area of work for us, whether we look at it at a global level in terms of international cooperation, or we look at it at the ground, or let's say the water level, when we speak of supporting governments and communities in need, for instance, in the small island developing states. My team has put together a small booth here on the occasion of the Geneva Health Forum as well. So for those of you who will be around today, please do visit the humble IOM showcase. But in particular, we'd like to draw your attention to our position paper on this issue of the triple nexus, where the migration health teams in IOM are working with our Climate Action Division. And we would very much welcome hearing from those of you who are interested in working in this area, because this is one topic where we do need more evidence from the ground in order to encourage our health sector partners and governments to also take action to address this issue. I'll stop here and thank you again for your attention and time.
Thank you. Thank you very much. Thank you very much. Very interesting. We are running a bit late, so really ask all the panelists to try to keep the time. And so it's a pleasure now to give the floor to Bernadette.
Thank you so much. First of all, thank you to the organizers and thank you to my colleagues here. It's good to see so many old friends and hope to make some new friends today. I'd also like to start by saying thank you to Carl and to Pooja and the Lancet team who've put together this amazing piece of work that you'll hear about later today. I'm going to start with a story. As the speakers before me have talked about a lot of things, I think it's time for a story very inspired by your work, Alexandra, and thank you for that so much and congratulations. So the story, interestingly, is also from what is Iran today, but was not Iran many hundreds years ago. And there was a group of people called the Parsis, a group that was exiled from the present-day Iran, and they arrived at the shores of India, on the western side of India, and to a place which today is called Gujarat. And of course, when they arrived, then they wanted to settle there. The ruler there, who was a very wise man, Rana, and they were agriculturalists, took a vessel of milk and showed the vessel of milk, which was full, indicating, we have no room for people. We have no room for people from the outside. So how on earth can we support you? The head priest of the Parsis was very wise. He took some sugar and he put the sugar into the milk. And of course, the sugar dissolved in the milk. And he said to the ruler that we will not only not displace you, but we will also enrich you. And the ruler then responded by saying, you're most welcome, only one condition. Please learn the language and also respect our customs and ways of life that we would do yours. So this was a story that illustrates that where we stand today is inclusion is very important. We're not here to displace one another, and we hear this rhetoric of othering very, very often. And the rhetoric of othering, the fear comes from not having enough data, not having enough evidence. So 5 years ago, the main purpose of the Lancet Commission report at that time, which was a landmark report, was really to dispel some of the myths. And that was very good. But dispelling myths is not enough. We need to then build on that and say, what do we actually know? Not only what we don't know. And in the last 4 years, we have seen an unprecedented amount of literature that has been produced. And I think we can say that we have enough data. As an academic, as a researcher, I can never stand here and say we have all the data we need. But there are issues with the data because the data is very much cherry-picked. And the cherry picking occurs, and we are to blame ourselves, I would say the academic community, but it's also the users of data. So this tango between the users and producers of data really needs to work better. where the users of data also come and say, this is what we need to know. And I think we've already been into that, and Santino has mentioned that, and Poonam has also mentioned how these collaborations are very important. So it's the type of data we need, and then the data that we have and the research that we do cannot be a flash in the pan. So we have the reports that are published, and then everybody's very happy, like we will be today at the end of the day, but that is when the work starts. And the issue here is related to the fact that we all function in silos. The way everything is organized, whether it's the ministries of health and the ministries of justice, every level, national level, global level, country level, local level, it's all in silos. And these are the silos. So you have the silos of the data producers, the data users, and among the researchers as well, there's a lot of fragmentation. So the work that we've done bringing all so many researchers today is to actually address this fragmentation. The WHO health agenda is part of that process as well, and the network, that the UN network, is part of that. So we need the knowledge to be put in practice. But then we have the policymakers who are very reactive. So how can we get policymakers to not only react when there's a crisis, but also have some kind of continuity? So I do agree with you, Santino, that we are really at a time of change. So we're standing at a crossroad where we have worked ourselves with all the global initiatives that have happened, enormous amount of work that has been done with many sectors. But now if we don't continue to bridge the silos, because I don't believe it's very easy to break down silos. We always say, let's break down the silos. It's easy to say that, and it's very good, ideal, but it doesn't happen. So how can we have the bridges between the research community, between the community, the civil society? The civil society is really there that moves and makes things happen on the ground and is in many ways the watchdog. And the one sector, which you rightly mentioned, Poonam, I was going to say that, is the private sector. We're really not engaged, and the private sector is not interested if we don't actively go out and engage them. So that's the second thing I would like to say, is that we need to see how we can bridge these silos between the different stakeholders, and very rightly, that has to begin at the country level, the way we do it. So, and what are our tools? What are the ways that we can do this? A lot has been already said, but I'm just going to try to crystallize it into something very simple. And everybody says, it is very complex. Yes, it is complex, but we need to embrace this complexity. We don't have a choice. And the only way we can embrace this complexity is by teamwork, which is exactly what we did with the work that we've done with the Lancet Commissions, with partnerships, which you see here, and the partnerships that have, continued over time, but they need to be strengthened. But we cannot do this without champions. And in every arena, we need some champions, and we need to find the champions. Many of them are in this room. So I think one has to also have an allyship between the champions in terms of how we can make this happen. We are at the Global Health Forum, and I think that very often migration or migrant health is seen as something not really related to global health per se. But if you look at the three big global health challenges that we have seen over the last few years, everybody says we're finished with the pandemic. I say that we'll still see the pandemics. That's one C. Climate change has been talked about, and conflict, which again comes and goes. And if you look at all of these three big global health crises, there's differential risk, there's differential exposure, and there's differential outcomes, which makes migration really an independent determinant of health. And we also know that, and I'm going to say it because I think it's the elephant in the room, migration is political. So why don't we just say it is political? And we have moved from just the social determinants of health to the political determinants of health. So unless we try to see that within that framework, and that's why the conceptual frameworks that researchers, that we as academia need to use, have to also change. We cannot only talk about social determinants of health. We need to talk about migration as a cross-cutting determinant of health, and we need to put it in the political framework. I could go on for a very long time, but I'm also going to, until the cows come home, but I'm going to let my other colleagues speak as well. And I'm just going to end with something that the chairperson for today in the morning said, and we have all these terms, and as a researcher, I love terminology, and it also, you see the power of asymmetry when you look at terminology. So in Norway, I'm a migrant, and a very visible migrant. But when I have worked for the UN, and when I am the ambassador's wife, because my husband is a Norwegian diplomat, I'm an expat, but I'm the same person. So sometimes it is the power that we have also within academia. Why do we use this term? Why do we put people in different categories? It is political, and therefore, unless we talk about those things, we can never end this. So, 3 things. We have to embrace diversity. If you don't like diversity, you need to find another planet, and maybe we will have to with the way we're going with climate change. The second thing is we have to embrace impermanence. There's nothing that is permanent, and COVID has really shown us. And in embracing that impermanence, we also have to embrace the complexity, not shy away from it. And as Gro Harlem Brundtland, who was WHO director and also Prime Minister of Norway, always said, everything hangs together with everything. Thank you very much.
Thank you. So thank you, Bernadette. So now, Kay and Katia, you have to do the miracle of trying to give your thoughts in a few minutes. Please, Kay, you have the floor.
I will try to watch my time, I promise, because I also tend to talk until the cows come home. But let me, we've talked a lot about international migration, so just for a moment here, let me take you out of this international framework and put you into another landscape. Because normally when we talk about migration and migration health, the one term that comes to mind, easily comes to mind, is usually international migration. But internal migration is something that's very, very rarely spoken about. Yet, in several countries, even including those who have nearly achieved or have achieved universal health coverage, you still have a gargantuan layer of population that is still being left behind due to their internal migration process because of the national legal framework. Now, I'm actually very happy that the previous speakers have spoken about evidence-based and data, etc., and I'm very happy to be able to prolong this discussion as a researcher to go into the academic point of view, because for the very first time, there is a collaboration between Switzerland and China, between the University of Geneva and Tsinghua University, Vanke School of Public Health, where we were able to gather a substantial amount of data from 2009 to 2018, specifically targeted at a nationally representative data set over this course of 10 years on the internal migrants of China. And when we're looking at this data set after we've done the analysis, we were able to see that despite health coverage being mandatory, despite the fact that this is a country that has shown significant progress on providing health coverage, not health care, but health coverage to a greater part of its population, you have this gargantuan nearly 300,000 million internal migrant workers who have a coverage that does not lead to access because they have left their rural village into another city or to another province, and the legal framework does not allow the reimbursement of the care that they seek to be provided. Now, within this data, we were able to see a strong inequality in terms of socioeconomic determinants. But what really shocked me, though, is that if we just kind of zoom out from this internal migration and we bring it into here, right here, everybody, the very heart of our discussion right here in Geneva. As a federally certified interpreter, I spent thousands of hours having the words and experiences of local migrants, their words flowing right through my mouth for thousands of hours. And Just let me bring you a few examples. A family from the Middle East, throughout their migratory process, they paid for their journey to flee their home country. They were deliberately left in the forest to their own device by the people who promised to bring them into freedom, without food, without any shelter, and without water. Yet, when they arrived here, when they were receiving social assistance, they were being told that they were encouraged to go into the nature, into the forests, as a part of their healing process from the trauma that they've experienced during their migration. A woman who was arrested from an Asian region for her religious beliefs, and that she has lost a baby in her womb because she was tortured during her imprisonment. A 15-year-old boy from an African country who left his country due to his sexual orientation had to watch his friend die in his arms, his best friend, because during their escape, they were treated in an inhuman conditions, and his best friend had contracted an infectious disease and were obviously unable to seek health care. So I guess what I'm saying here is that the shock that I felt at how quickly whatever we were able to observe from a statistical vantage point, how easily it gets translated into field experience right here in the heart of this migration health care access and migration, this discussion. So I guess I will cut it short, as I promised. That as a researcher and as an interpreter, and I'm very, very happy that we're talking about collaboration, how to go into the local experience, how we can no longer work in silos. What are the toolboxes? We need to look at who are at the forefront. Social assistants. These are the people who are working directly with migrants. Medical professionals. And well, I'm biased because I'm also an interpreter, but yes, interpreters as well, like we saw in the film earlier on. I think as a researcher and in my role, it's actually very, very important now that not only do we need to start a discussion from top down, but there's a critical importance that we need to work from bottom up. Because that is where we're going to be able to really grasp, go and seek at the bottom of the drawer to really leave no one behind, like what Alan has said earlier. Yes, migrants are resilient. They really are. I'm a migrant myself, as you can visibly see. But we cannot count on their resilience alone. We need to really act together and look at who is working in the field and seek them out. Thanks.
Thank you very much, Kay. And now, last but not least, Katya, please, you have the floor.
Yeah. Hello, everyone. And I really want to thank to the Geneva Health Forum organizers for prioritizing this topic. Unfortunately, it became more and more important, and just with the years, with the growing number of migrants, internal and external. I'm from PASS. PASS is a global nonprofit organization headquartered in Seattle, United States, and working in more than 90 countries in the world. And in Ukraine, PASS works for 30 years, implemented just a wide range of the projects different. And you know, when the Russian invasion in Ukraine started and in February 22, and it's resulted in a massive number of internal migrants. According to the International Organization of Migration, 7 million people, internal migrants, plus 8 million refugees. I would not focus on refugees. I would speak on the internal, just migrants. And we already were implemented, I just tried to be very short, that's why I will squeeze information. So we already implemented our work in the country and just implemented tuberculosis project funded by USAID, the COVID that resulted. And then you can imagine 7 million people, they appeared as IDPs within 3-4 weeks. They moved to the Western countries, they doubled population in many communities, just literally doubled. So they were put, it's a winter, It's a February in Ukraine, it's pretty cold. They were put in shelters, overcrowded. Most of them were aged people, children, and women, young women, very stressed and really needed access to essential health services immediately on the spot. And we reverted our activities aimed at TB and COVID. We added the on-the-spot services immediately provided in these shelters, combining multidisciplinary mobile teams. But how we did this? You know, the resources were already very limited and overcrowded. You can't pull the person from the health system and put it into mobile. So we really just looked at what was available, and we really looked through found the health providers within IDPs, nurses, primary health care providers. That's why these teams, they were not rigid in the number and professional scope. Sometimes there were 3 people, sometimes 7 people, infectious disease providers, primary health care providers, and so on and so forth. And by that, we reached during this couple of first like 3-4 months, 36,000 people, nothing comparing to 7 million, but still it's a significant amount. Just, it's also, I forgot to mention, it's also overlapped with the, again, just a significant increase of the COVID Omicron strain. You know, and we also provided, because it was part of our scope, and apparently we found out that the willingness to get immunized increased significantly. We immunized more than 18,000 people out of 36 reached, you know, during these visits. But then, after this first couple of months during the summer, all these, you know, people, they left these shelters and were set in the communities, in the big cities, in the small towns, and in the remote rural places. And especially in the remote places, what we faced, that there were sometimes no health providers already, because they were also women with the children, they left sometime, or were one per health nurse for the community, and then it's a huge number, just new people came and they appeared. And the access to services, to health services, first of all, was really very small. And what just we decided in consultation with the community to create for Ukraine very innovative, not necessarily in the world, to create health access points, which were pre-health services, you know, like screening for the major non-communicable and infectious diseases. And sometimes there were health workers or nurse leading this point, sometimes volunteers like librarian, or sometimes it was a budget, the counter, whatever. We conducted training, conducted for them, for these people, and in this case established pretty rigid monitoring system and supplied them with the major, very simple but access, you know, like a blood pressure, you know, just in the blood glucose, self-test for HIV and so on. And you know, it appeared to be extremely sustainable. Honestly speaking, it was like an experiment for us, but you know, just basically we tried. We tried what is possible, because these people really needed services. And it grew up so significantly. We started with 5 and grew up to right now to more than 17 and continue growing, and it's a big demand. And we also added services, mental health, very preliminary, you know, just like screening and immunization program and something like this, you know, just on some others. And it's actually the set to grow to broader. And this now finally I can translate the sentence community health. I always challenge to translate this into Ukrainian because it didn't exist, and now it's really started to exist. And we did not, you know, just it's not to overwhelm you with the numbers, but only just to illustrate. During 3 months of this year, January, March, we specifically just looked at the younger people before 40 who were just screened for blood pressure on their own wish. They are beyond, outside of the regular screening, you know, approach. And apparently 10% were diagnosed with the high blood pressure. I forgot to mention, in both cases, in mobile teams and here, we also established a referral pathway mechanism. Not just to refer, you need to go to see a doctor because you have problem, because it would, you know, face the wall, but also facilitating this visit to the doctor, provider, and monitor the follow-up and feedback. So 10% were only diagnosed, referred, and followed up. And just in conclusion, I only want to say, I'll just try promise to be short, that our lesson is that you need in such a urgent situation, in case, definitely research is extremely important, definitely strategy is very important, but you also should be flexible and use what you have right now and, resources, what are available, but also communicate permanently with this community, with IDPs and with the hosting communities, because they both have their own needs. Not necessarily these needs are the same, You need to listen both and to facilitate their dialogue, which is extremely important. I know that within Ukraine it was not so acute like in many other countries, but for example, language discussions where, because Eastern Ukrainian came with the Russian language, and in the West, they came to Western Ukraine where no one wanted to hear this language. So there were many discussions. And I also wanted to say that a lot of information we received informs the research agenda. We really need to, as much as research has been done, we really need to go in depth in finding out what would really work and what would be the result and feedback. Thank you very much.
Thank you, Katia. I was planning to open the floor for discussion, but unfortunately there is no time. I apologize for that, but really the talks were very interesting and inspiring. There will be the full day for discussion, so if you have a specific question, please approach the panelists during the coffee break, and please join me in thanking very much all the panelists.
Thank you all for your contributions. You can now leave the stage. Thank you very much. It was very dense and rich, but yet we keep the conversation going. It's not over, just if you can stay for one more minute for those who want. So you remember we had a question at the beginning that you had to answer. So 93% of you got it right. It was answer D. So all of the answers were true. And yeah, we're coming to the end of the session, so we'll meet again at 11 a.m. for our next panel. Thank you very much.